Well, thank you everybody for coming to the Surgical Grand Round. I have great pleasure in introducing my colleague, Professor James FitzGerald, who is an Associate Professor of Neurosurgery in Oxford. He trained, he did a degree in physics at Oxford University a number of years ago, and then decided to do a degree in medicine following that, also in Oxford University. And then following some house jobs in Nottingham, he then defected to the other place where he did his PhD looking at neural interfacing on peripheral nerves. He then came to Oxford, where after doing his neurosurgical training in Cambridge, he then came to Oxford as a consultant and an academic, and then put his efforts into his Oxford Neural Interface Group, which spends most of its time working on some of the things that you're going to see today, but all sorts of prosthetics and interfacing between essentially electronic devices and nervous tissue, whether it be the brain or the peripheral nervous system. And so today you're going to see a really interesting project looking at stimulation of a peripheral nerve, and it's a quite profound effects on ventilation. So without any due waiting, let's have Professor FitzGerald.
Thank you very much indeed, Alex, and good morning, everyone. It's a great pleasure to be here this morning to tell you about a project that we've been working on for the past 2.5 years, which perhaps gives away the fact that this was a COVID-inspired project, although since it's become something with wider applicability. There we go. So as Alex mentioned, we work on a bunch of stuff to do with nerves and electronics, and clinically the job Alex and I both do is to implant electrodes more or less wherever in the nervous system, from the brain for movement disorders to the spinal cord, dorsal root ganglia, peripheral nerves for control of pain. And the group's research at a more basic level looks at implanted devices as a long-standing project in peripheral nerve implantation, but more recently brain-computer interfaces, muscle stimulators. And in the recent past, we've taken a fork towards non-invasive neural stimulator devices. Now, all of that was going reasonably well, and then, of course, that happened. We were sitting there at a lab meeting with no patients, closed laboratory, wondering what to do next. At this time, we were feeling slightly embarrassed and inadequate because there were a whole load of people running around building ventilators in very, very clever ways. And many groups around the world are doing this. And this is just a selection of them. I'd like to highlight the one at the top in the middle, which is the Oxvent project, led by Andrew Farmery, one of our own, which has been very successful. And I've seen from their website, they've got a much shinier, more polished looking device now. So that's really taken off. But there have been many people working on this around the world. Top right there, you can see a ventilator made of wood, which probably is something you haven't really seen since about 100 years ago. This is from Rice University in Houston. Top left is Imperial College's offering. In the middle at the bottom, that's MIT. Richard Branson got involved with his Virgin Orbit program. At the bottom left, mass producing ventilator devices, all of these based upon squeezing an amber bag. And then there's some more slightly off-piste approaches involving the use of diving masks at the bottom right to do a different way of ventilating people. The problem that occurs fairly quickly after you start mass producing these things is that you can build a ventilator and another ventilator and a bunch more, and then a whole load of ventilators. And people were talking about needing tens of thousands of these early on in the first wave. But after that, you work out that there's a problem with staffing this, because for each one of these, you need a staff member to look after the machine and the patient attached to it. So you can start off pretty well, and then you can rummage around and find some more people who aren't already working on ventilated people in other parts of the hospital. But after that, what do you do? And the fact is that unfortunately you can't build staff. And this would have led to a massive problem if we'd ever had to use the Nightingale hospitals. There were 7 of these built around the country. And this is the London one, it's the biggest, and it would have needed 16,000 staff, because for every bed, you need about 4 staff once you've worked out shift patterns and so on. So we'd have needed 16,000 for this one, 50 to 100,000 to staff all the Nightingale hospitals around the country. And it's a good job we never needed them. This one treated 54 patients, largely step downs. A couple of the others treated absolutely nobody, but we'd have been in real trouble if we'd actually needed them. So we were sitting there thinking, well, we don't know how to build ventilators, and more than that, there's a group down the corridor doing an excellent job of it. So we don't really have much to contribute there. What can we do with nerve stimulation? And we hit upon the area of ventilator weaning, because if you can wean people from a ventilator faster, not only do you get the ventilator back, but you get the staff. It all comes down to a problem with the diaphragm, which, as we all know, is the main muscle of breathing. Sure, you've got intercostals, you've got accessory muscles, but the diaphragm does the bulk of the work. It's a sheet of muscle. It's a couple of millimeters thick normally. It flattens to draw air into the chest. It's driven by the phrenic nerves, which for embryological reasons originate from the neck, from the mid neck, and they then run down through the low neck and through the chest to reach the diaphragm. Now, diaphragm is a skeletal muscle, and with skeletal muscle, activity is critical to maintenance of muscle mass. It's a use it or lose it situation. It's a bit like going into space and what happens to your bones if you're not using them, loading them, they're actively deconstructed, and skeletal muscle is the same. Anyone who's done a sort of binge at the gym and then a gap, like I have many times, will know that you bulk up and then you lose it fairly shortly afterwards. And when you're ventilated, the diaphragm's doing absolutely nothing at all. So it's not like your leg muscles, when you're not at the gym, they slim down because you're not exercising them as much. If you do nothing at all, they waste away very quickly. Quadriceps, for example, waste of quadriceps is a good reason why a lot of old people have difficulty getting out of bed after a prolonged stay in hospital. The same is true of the diaphragm, and the total lack of drive during mandatory ventilation, as well as the relative lack during supported modes, causes wasting. And this is called ventilator-induced diaphragm dysfunction. It proceeds quickly. So it starts within a day, and within about 3 days, as you can see from the graph on the right, you've lost 25% of your diaphragm thickness. So that one's gone from just under 2 millimeters in this group to just about 1.5 millimeters within 3 days. And the loss of strength is disproportionate to that. So this group have probably got diaphragms that have lost about 50% of their strength. This is quantified by ultrasonic measurements of diaphragm thickness, which is one of the accepted ways of measuring this phenomenon. The other one being generation of airway pressures by diaphragmatic twitches, which can be measured. And both the diaphragm thickness and a reduction in airway pressure due to diaphragm pulse are correlated with this problem. So what's the solution? The question is, can we maintain the condition of the diaphragm while we're ventilating? Well, we think yes. We think, as I was alluding to a few slides ago, the answer is to exercise it. If you exercise it, you'll maintain its condition. And evidence from skeletal muscle elsewhere is that just a couple of hundred contractions a day is enough to maintain muscle mass. Now, for the diaphragm, that's about 1% of the contractions that we normally do every day of our lives, 12 to 20 breaths a minute. But still, theoretically, this should be enough. And that's one powerful contraction every 7 to 8 minutes. So to do that, we have to activate the phrenic nerves. And here's the anatomy. The phrenic nerve comes, as I said, from C345, the major contribution being C4. It emerges from the lateral border of scalenus anterior and passes down over the anterior surface of that muscle highlighted here in pink. It then goes posterior to the subclavian vein to enter the chest, where it passes down anterior to the lung root over the pericardium. This is the diaphragm and supplies it from its underside. Turns out there are at least 3 other solutions out there to stimulating the diaphragm already. 2 of them, the top 2, motivated for the same reason that we're looking at. So the top one is a modified central line that's passed in the subclavian vein and used to stimulate the nerve. The middle one is wires that are inserted percutaneously into the neck through a needle to lie next to the nerve. The bottom one is electrodes that are inserted laparoscopically. This is the external control unit. The electrodes on the inside are inserted laparoscopically into the diaphragm. That's way too invasive for this application. I put that there really for completeness, but that's mainly aimed at people needing ventilation in the longer term after cervical cord injury. So this is the transvenous approach. You get a modified central line. It's got electrodes on the outside surface of the line, and you pass it like this into the subclavian vein. And the vein, as I mentioned, passes close to the nerve passes immediately behind it. And you can stimulate the nerve through the wall of the vein because they're close proximity. That is on the right, the control system. This is being made by a company in America called Lung Pacer. The system's called Transaeris. It's already had quite a lot of clinical trial work done. There's one of their papers, but they've been through a feasibility study, Rescue 1. They've been through an efficacy study, Rescue 2. It's a great name, Rescue, isn't it? It's one article a few years ago about the naming of trials, highlighting that some of them are slightly coercive in terms of recruitment. One trial in the past called the Miracle Trial, for example, but Rescue is probably milder than that. Anyway, they've been through Rescue 1, N is 11 feasibility study. Then they've done a larger study with recruitment of 112 randomized 1-to-1 stimulation versus no stimulation, and showed significant improvements in the physiological measures that I mentioned in diaphragm muscle thickness, in inspiratory pressure, and a non-significant trend to reduction in duration of ventilation by 1.4 days. Now, it's a very significant length of time. But it's a horribly messy variable. It's a horribly noisy variable. If you go into the ICU and at 5:30 in the afternoon, you think this patient's just right now, they're ready for extubation, then you will not have that patient extubate until 8 o'clock the next morning, because the last thing you want to do is take a tube out and risk failed extubation in the evening. So trying to measure reduction in duration of ventilation, which is the clinical variable that we're all interested in, is quite difficult and will require a lot of people. And for the pivotal trial, which is now recruiting in accordance with that, they're looking for a target 400 patients, again, 1-to-1 randomized. This, importantly, is a study that's done in a group of patients who already have diaphragms that are in a really bad way. These are a group who've been ventilated for at least 4 days and had 2 failed extubation attempts, so that we know that their diaphragm is in very bad shape. And the idea of the system being used here is to build it up again, which is different to what we're planning to do. The other approach is percutaneous wire passed into the neck. That goes in a bit like the animation here. It's inserted from more posterolateral position, passed along a needle to lie across the nerve like that. Ultrasound guidance used, and simulation is straightforwardly through one of the contacts. You have to determine which contact to use by trial and error, essentially, once it's inserted. You can see the device on the bottom left there. Again, it's made by American startup StimDiar. The 2 wires you can see clearly. The third item there, which is the darker cable and the black unit on the right, and you can perhaps just see a Perspex tube running through that. That's an airway insert. So that goes in between the ventilator tube and the ET tube. Just unplug them and plug them into either side of it. And that provides airway, airflow sensing, and a means of determining ventilatory phase. And that's really important. That's something that's in our design too. The point of that is that you need to make sure that you're putting an induced diaphragm contraction, which produces inspiration, in the inspiratory phase, so that you're not fighting the ventilator. This is at a much earlier stage of development. They have done a pilot study of a similar size to the other one. Their main goal with that was to see how well they could capture the nerve with the technique, and then it managed to do it 95% of the time, which is obviously very good. But it did take an hour of fiddling around to get the electrodes in the right place and to get nerve capture, which is significant because you've got an operator there with specialist knowledge tied up for an hour. and that won't be available all the time. So the issues with the existing systems are the requirement for specialist skills to insert them. As I've just said, that's a lot of the time of somebody who's skilled in ultrasound and probably skilled in many other things, and is therefore being pulled in different directions to do all sorts of tasks. There's obviously a risk profile. Not everybody who's ventilated in ICU has a central line, and they will all need one for this, and that comes with its attendant risks. The implants will be relatively expensive because they are invasive, and some of these systems, not the one with the respiratory sensing as I was showing below, but some of these systems that don't have that need to be supervised in use. So you might have a physiotherapist, for example, supervising the session. They tend to group their 200 stimulations into an exercise session of an hour a day. To facilitate that, we've chosen to distribute ours around the clock on the grounds that then any disruption to routine, for example, the patient goes for a scan or has to be washed or something like that, you might lose a few of the contractions, but you'll still have most of them, as opposed to potentially losing the exercise session if it's grouped together. Because of this profile of cost, skill requirement, risk profile, that's what's driven the deployment of these things in a setting of a limited number of patients where there's failed extubation. So they're really going for the group that these things could maximally benefit, but the generality of patients don't get this. And our perspective was, why can't we use it from the outset preventively? So to do this kind of thing at scale and in any location, because we're very conscious that this is not a first world problem alone, you need something that requires no specialist skills to set up, because they won't always be there. You want something that can run unsupervised, so you're not tying a staff member up watching it while it happens. You want minimal risk so that we can deliver it to a lot of people and not add to the problems of a system that was already stressed at the time. And we want cheap components, so there's no barrier to widespread use. And that leads to the question of, can we do it non-invasively with surface electrodes on the skin? Because if you can do that, then you have something relatively cheap, virtually risk-free, and if you can apply them using very simple surface landmarks, then you get rid of the need for specialist skills as well. So the question is that actually possible? And is it possible also with no pressure? So typically when you're stimulating a peripheral nerve, you'll get a handheld probe. If you're doing it through a nerve conduction study, for example, you'll put it over the nerve and you'll apply a bit of pressure, which brings the tip of it down into closer relationship with the nerve. People have done this with some sort of caliper applied to the neck to put bilateral pressure on electrodes to stimulate the phrenic nerves, but in ITU that's unacceptable. You'll get pressure sores very quickly. So it needs to be done without applying any pressure to the electrode at all. We need to cope with anatomical variability. You know, people are different sizes, the nerve's not in exactly the same place in everybody. And there was also an issue of, we were worried about, does the relationship to the surface change with head position? Because at the time of COVID, we were of course turning people prone, and then when you turn people prone, you can't have the face burying the pillow, so the head gets inevitably turned to extreme lateral. And so does that rotation actually move the skin carrying the electrode laterally or medially with relation to the nerve? We had, unfortunately, a great collaboration. Got all of these people have been part of the group, lab meetings every week on Teams. It's been a great group to have. We've got Brian Andrews, who many of you will know, who's got a lifetime's experience in functional nerve stimulation. Connor, who's my current most long-standing PhD student, has been heavily involved in this. Adrian is an emeritus professor from the Open University, who's an electronics design engineer. Jonathan is an internationally known muscle physiology expert at Liverpool John Moores. And Francisco's a postdoc who was with us at the time, who's now back in the University of Conception in Chile, and has his whole department interested in this. And it was a great collaboration, still is a great collaboration. They had peaks of COVID at different times to us. It looked like something that actually provided a lot of extra resource, not just in terms of patients also, but in terms of a group of 10 or so people. This was the concept that we came up with. You can see a sort of system diagram on the left. It's got in green some sensors, and this was all about determining respiratory phase. The key one's the one in the endotracheal tube, which works in the same way to the stim dia system I showed a couple of slides ago. That's for sensing respiratory phase. It's also automatic means of outcome measurement, because we deliver stimulation through these electrodes over the neck, but we can also measure what we're evoking with that. So the sensor will not just measure what the ventilator is doing, but will measure what we achieve by stimulation. And as time passes, we can use that to determine the time course of atrophy, whether that's proceeding fast, whether we've managed to slow it down, and we can derive outcome measures for that for use in studies. The other green lines measuring ECG and diaphragm, EMG. We're also measuring the mechanomonogram using accelerometers. All of those we've kind of parked to one side at the moment because the signals from them are just not as good. Diaphragm EMGs actually turns out to be quite hard to do reliably, whereas a sensor in the ET tube is directly measuring the phenomenon of interest. So for the moment, that's all we're using. Brian's pioneering an approach looking at lung sounds as another way of determining flow, and that will be a key development, I think, for some of the applications I'll mention later, where we're thinking about using this in people without actually a tube in for different applications, and so the inline sensor wouldn't be applicable. The other key aspect of this is the stimulation, which is delivered not through one electrode but through an array. So we have an array of electrodes on the neck, and the system will poll the electrodes individually. When it's setting itself up and initializing, it will go through them and test each one and determine which one is the best. This is how we get around the anatomical variability problem and potentially the change in position that occurs with head turn. This is an early set of data from the Chilean branch, and you can see there probably got bursts of stimulation pulses delivered to the nerve, which is what you can see at the bottom. And then from the top, we've got diaphragmatic EMG recorded very carefully. As I was saying, I think this is going to be very difficult to do in the generality of patients in intensive care, but it shows what you can get. But then you've got flow and pressure, and these are waveforms that you can readily get from the airway insert. And just for completeness under that, you've got the mechanomoograms showing the shocks emanating from the diaphragmatic contraction. That, as I was saying, this is our first design of electrode, which is actually made from a whole bunch of TENS electrodes that have been cut up. The 6 in the line are the cathodes, and the ring around it are being used as a positive return electrode. And what we do is we cycle through those cathodes to determine which one has the best effect. The landmarks for this are very simple. You find the cricothyroid membrane, the cricoid cartilage underneath it. The medial end of that anode goes there in the midline, and then it's just positioned directly laterally running from that. So anybody who can find the cricoid cartilage can apply this without further training. We've published a healthy volunteer study, so we started off by testing this on ourselves and our friends, obviously with the appropriate ethical approval, and published that in January this year. And Connor won a prize at the conference for the presentation, which was very pleasing. This is an example of some of the recordings. You can see the 6 electrodes represented there on the graphs at the top left. You can see that it's cycled through the electrode. It's got what's clearly the best response at number 4. On the right, you can see the response in various head positions, centered, extreme left, extreme right, which it turns out makes no difference at all. And the 464 is the number of people in the group of 14 who responded best to each electrode. So you can see nobody really responds with electrodes that are very medial. but there's a significant variation in best response position, which occupies the lateral half of that array. And the response away from the optimal electrode is much less strong and requires much higher drive current to achieve, which causes side effects, as I'll show you in a minute. So it really is key to get the position right, and that's really one of the innovative aspects of this approach of scanning through a surface electrode array to determine the best location. The optimal position, as I said, does vary between individuals, but perhaps surprisingly not with head position. So once you've determined it, as long as the electrode stays in place and doesn't come off, then you should keep that value. But the system will check every so often that it's still getting the best response, and it always monitors the response in the airway. And if it fails to see a response, then it will go back and repole these to see what's going on and run other diagnostics to make sure the electrode's not fallen off and so on. The gel that's used on these electrodes is extremely sticky. The company that makes them says they're going to stay on for at least a week, which to anyone who's had ECG electrodes falling off regularly, it's quite surprising, but believe me, I've put them on and it really is tough stuff. And indeed, they said don't put them on you if you don't want it there for a week, because you'll struggle to get it off. This is just the electrode selection again. You can see that the onset of stimulation is at the left side of those graphs, and you can see that electrode number 4 is the only one with a very clear-cut response. This is a strength duration curve. So what this shows is that the left side of that graph, you can activate the nerve with a high amplitude, brief pulse, or as you go to the right, you can use shorter pulses, longer pulses with lower amplitude. And this hyperbolic relationship is typical for nerve stimulation. And it just shows that this is sort of obeying the normal rules of nerve stimulation. The dotted lines are the data for each individual, which is quite noisy, and then the darker black lines, the mean, and the solid lines, the fits and that. But this just verified that the nerve was behaving as expected. We then have a process of iteration. So the system starts off by delivering a certain level of stimulus current, which is on the left curve, so the leftmost dot. If it achieves successful stimulation, we'll halve that and then determine whether stimulation was successful. If it won't, it will then increase to halfway between the last two. And by doing that, it iterates and it levels off and converges on the threshold current. And you can see that on the right, above that, you get full activation. Below that, you get nothing. We then go maybe 20% above that just to make sure that we have appropriate activation. And the currents do vary quite wildly between people, largely depending upon whether you have a thin neck or a somewhat bulkier neck. This is a response to frequency. Muscles don't produce fused tetanic contractions at low frequencies. You need to go up to a few tens of hertz really to get optimal results, and we decided to settle on 50 hertz stimulation. Now we have a flow sensor in line with the ET tube. This is not of our design. It's OEM, just means it's an unbranded component supplied by industry for anyone that wants to incorporate in their device. The purpose of this is to stimulate in sync with the ventilator and not fight it. And that's really important. Some patients have really brittle lungs, and you can upset the apple cart in a big way with just a single breath that's not in the right place. So we found that these systems are very robust to noise, because they're not measuring something electrical, which would be subject to a lot of radiated interference in ITU. And we've tested this. Connor's tested these for the equivalent period of months and found them not to generate any false positive triggers. There's an example of what happens. You can see the inspiration and expiration phases on this flow plot, and then we get in the middle at time zero. We're into an inspiration, and we just add some. And here is Connor, having the system tested on him. If you turn your volume up now, at some point you will hear a breath. And that breath was the system, not Connoisseur. He was breathing there at just quietly breathing, which is the grey trace that you can see going on, and then the system detected the inspiration, added that. And that's a very strange feeling when you have it done. I can tell you, to feel yourself just breathe without actually the intention of doing so. But it's very robust, it's reliable. It's not, I have to say, the most comfortable thing to have done in a conscious person. You may have seen a little twitch there. It was a combination of a bit of activation of platysma and possibly sternomastoid, a little bit of shoulder twitch probably on the end of that. And I'll come back to those in a minute. Once again, for anyone who didn't catch it the first time. So the key points of this is it's a non-invasive system. We've got application using simple surface landmarks, no special skills, synchronized with respiration, so it doesn't need supervision. Detects the optimal electrode location and current required automatically, and measures its own outcomes. It can't do ultrasound of the diaphragm, obviously, but it can do everything else. It can measure, it can stimulate, it can give a pulse to the diaphragm, measure what happens as a result. So 3 or 4 times a day, it will collect its own outcome data as well. Now, it was COVID inspired, but of course, COVID was here for a very short space of time in retrospect, in terms of people, large numbers of people acutely and on ITU. And so it was never really realistically a timescale in which we were going to develop something like this. But what do we do with the idea? And really, obviously, it's relevant to future waves of COVID. But the big point is that it's really relevant to a lot of other intensive care patients. And you see that if you just look at the numbers. Some 40% of the time on a ventilator in intensive care is actually the time after your primary illness is abated and you're trying to get people off the ventilator. There are tens of thousands of people ventilated in the UK, most of them for the better part of a week. So these people are going to be well into the risk period for diaphragm atrophy. Now, a lot of them are kept on spontaneous modes of ventilation as much as possible, which will mitigate that to some extent, but not completely. And so you can see that if you were able to halve that time, if you could reduce weaning to 20% of the time, you'd be saving well over £100 million a year. So benefits for the patient and benefits for the system. I mentioned earlier on other applications potentially, and there are. We're not, and we need to be very clear about this, we're not using this as a ventilator. It's not doing significant amounts of ventilation. It's only giving one contraction every 7 to 8 minutes. This is being used as an exercise device to maintain muscle condition, and that's it. But you could use it for ventilation. So there are a group of patients who have high cervical cord injuries, who aren't breathing to begin with, but that will recover over a period of weeks to months. And for those people, if you can have negative pressure ventilation driven by diaphragm contraction rather than positive ventilation by having a tube down, they're much better off. And this is one potential application. There is actually a company out there making cuirass devices, so miniature chambers that fit around the chest in order to, by evacuating them, generate negative pressure, enlarge the chest and draw air in as an alternative to positive pressure ventilation. And this certainly has its applications. And you know, not having a tube in saves you potentially from a lot of complications. And there will be a place for that. It's called biphasic cuirass ventilation. And that's potentially an area that this could do a similar thing to, generate negative pressure, not by having a chamber around the chest, but by depressing the diaphragm. And we've considered applications to resuscitation. You know, defibrillators are very automated these days. You have pads that you just put on the chest and leave it to it. Perhaps you could also have electrodes and put them on the neck and deliver the rescue breaths. So those are all for the future. There are some issues if you would want to use this in people who are awake. In particular, there's strong activation of cutaneous afferents under the electrode. So it's not that pleasant. having the stimulation if you're awake. As I said, you get this really quite strong pinching feeling, and some of the sort of twitching you saw with Connor there might just have been a bit of a grimace as well. There's also the potential with higher currents to get some shoulder twitch, and I think there may have been a little bit there as well, and that's because between the anterior medial scalene just in the back there, you can see those black lines, which are the brachial plexus, of course, and if you stimulating too hard, you will penetrate through to that and get some shoulder twitch as a result. That's something I'm fairly confident we can iron out. We've managed to drop the stimulus current probably by about half, and that's really cutting that out. And if you avoid using electrodes at 2 lateral, it's when you're using electrodes out of position 6 in a patient who really wants to position 4. That's when you tend to get most of the plexus activation. The cutaneous sensation is something also I think we'll be able to get around using different types of stimulus waveform. So those are areas for further development. Where are we with the project? Well, everything in green we've done. The orange step of actually putting it together is nearly there. We've been supported by the University Challenge Seed Fund, which is something comes out of Oxford Science Innovation. It used to be Oxford University Innovation, which is venture capital group strongly affiliated with Oxford University Innovation, which is the tech transfer part of the university. We're now designing the first clinical studies in conjunction with the trials unit in Aberdeen. Sadly, because of all the other things Oxford was doing, they didn't have the capacity for this, but we're very grateful for Aberdeen for stepping in. They've got a lot of experience with device trials and trials in critical care, and there's also a burgeoning collaboration between Oxford, Bristol, and Aberdeen in surgical trials. So they've been extremely helpful. Phase 1 is going to be a pilot study. It is just going to be the same question that the percutaneous people asked, i.e., can we stimulate in this way in patients in intensive care? Does it actually work? Do we get nerve capture? Assuming that answer to that is yes, then the efficacy study is next. And like the lung pacer trial, we'll be looking at physiological measures in that stage, because these are hard numerical values that you can measure: diaphragm thickness, pulse pressure response. Clinical variables are for later, once we've got a clear steer on whether the device is effective on a physiological measure, because a clinical study for clinical outcomes will mean hundreds of patients. And the difference between what we're doing and what the others have done is we're aiming to put this on at the outset in people who are anticipated to be ventilated for more than a couple of days, in order to try and prevent atrophy rather than treat it once it's occurred. And we'll get an idea from the earlier phases about whether that's something that needs the same number of patients as the other approach or more. So we're not anywhere close to being able to design the study to look for clinical outcomes at this stage. This is the device, as I was saying, we've pretty much got it put together, and we've managed to do that largely by outsourcing parts. We're having circuit boards made in China with batteries from America, electrodes made by a company in Finland. The only British bit is the box, unfortunately, but that's the way of the world these days. So what we're doing really is designing all of this stuff, asking people to make it, and then it comes back to us, and we add some critical bits to the boards, put it all together. Has a fairly standard keypad on the front of it, membrane keypad that's white clean, that you'll recognise from many medical devices. And we can, by doing it this way, and not having to assemble every last bit of it, we can certainly cope with putting enough together to run the first 2 stages. That's it. Thank you very much. The people here are the many people in the large team across the UK and Chile who were involved in the LD volunteer study. Martin Gillis is senior fellow associated with the group who steps in and is helping massively in trial setup. and approvals and so on. And at the bottom, these are all the members of the group who've pitched in at various stages and working on the many other exciting projects we have that I've not had time to go into. So thank you very much, everyone.